hearing from the news about, but maybe not have been getting that sort of clarity and real-time information. So Dr. Chen, please, Yen, go ahead.
Hello, can everybody hear me?
Yes.
Yep.
Okay, good. So I mean, I assembled some slides, but I know that there's a lot of information out there in the web or over in chat rooms and on TVs. So feel free to drop me a note, because I think those are the things that I thought that maybe general things that may be good to share. But of course, if there are other things that you like to know, I'm happy to chime in what I know. Right. So let's get on to the slide. I think, well, I'm a Singaporean PR, and my wife and kids are Singaporean. I spent 15 years as a PR now, and now I'm based in Bay Area. I graduated from UCSD, and I specialize in virology. And especially when I was in graduate school, I did the HIV. At that time, it was also the hot topic because everybody is working on that. It's a little bit similar to the COVID-19 now, but I see a lot more collaborations between the academic, pharmas, and biotechs. So that's one thing that I want to point out. Everybody is trying to see what they can pitch in, and of course, volunteers, pharmas, all are very, very important. So the other thing is that I also did my training in the local Institute for Cancer Research, and right now I'm working in the Novartis Institute for Tropical Disease. So I've been in the industry for 15 years, and I'm happy to share what I know about this COVID-19, right? So next slide. Yeah, all right. So COVID-19, it's also known as SARS-CoV-2. SARS is the original SARS is now named as SARS-CoV-1 or SARS-CoV or short-term SARS. So it's an RNA virus. It's a cousin of DNA. So a lot of people know DNA as their genetic material, but this particular virus, it carries an RNA, which is very close to DNA, but somewhat different. So it spreads mainly by contaminated surface and close proximity to infected human. And one thing that to note is that majority of the people that got the disease are asymptomatic, and the mild cases account for less than 30% of the population, and the severe cases account for less than 10% of the population, and within that, less than 5% actually went into ICU. The the prognosis for ICU is pretty dire, and if you are actually on the ventilator, which is a very, very small amount, minority of the patients, is probably 2% right now. You probably end up in dying. A lot of time when you see the statistics, the death rate is very high. That is mainly because that there is no adequate testing for those for people, and more people are realizing that there's a lot of asymptomatic patients, and that means that they don't even feel that they got any disease. So it's something that to keep in mind, that even if you got that, majority of the cases are mild, right? The other thing is that it takes 2 to 14 days to appear, with median incidence of 5 days. That means at around 5th day, half of the population already shows symptoms, and if at all. And the other thing is that for those mild ones, the symptoms usually resolve within 2 weeks. And for those more severe ones, it takes a longer time, usually 3 to 6 weeks, and they sometimes also stay in the ICU. So for severe cases, it does take a lot longer to get resolved. And of course, death is one unfortunate result of that. So right now, there are currently no vaccines and treatments available. So all the treatments are supportive in nature, and that's what it is now. On the right, it shows that the virus in the schematic diagram of the virus, and the receptor is called ACE2. It's a protein that is very, very prevalent in tissues. So this virus can affect a lot of tissues because of the fact that they use this particular receptor to get into the cell. All right, next. So common symptoms are fever, fatigue, dry cough, shortness of breath, and just put up the comparison between the COVID-19 and other conditions. So if you're sneezing, usually it means that it's not, if you're sneezing, that means you're probably not having this COVID-19, because it's not, it's almost extremely rare incidents that COVID-19 patients have sneezing. And the other two things that are really up and coming is that the loss of smell and taste and severe chills are the two additional symptoms that they pointed out. And when they go back to the SARS virus outbreak, a loss of smell is also one of those symptoms that are being put down. But at that time, a lot of people doesn't realize that that could be one of the defining symptoms that for this disease. So if you have loss of smell and taste with fevers and dry cough, it's a pretty good diagnosis that you may have this COVID-19. So next is what is happening in California and in Singapore. In California right now, there's more than 40,000 cases confirmed, and with more than 1,500 deaths. One thing to note is that luckily they are leveling off in many parts of the California. Part of science growing and still growing. To read this curve, the steeper curve, that means that the faster the patients doubles. So if you look at like Santa Clara, on the far left, they are pretty much leveling off, although Santa Clara in here is one of the most affected. But right now it appears that they are leveling off right now. So in Singapore, there is a spike lately. One, of course, that's been discussed. And one thing about this is that we have very few deaths. It could be attributed to excellent medical system, younger patients, because this particular disease strikes more severely for those older patients. So next. So next slide. So how the infection is being measured is by this R number, which is the reproduction number.
Oh, do you mind? I inserted this slide because I was very curious. So actually, Dr. Yen, you're just going to the next slide. Let me just talk through this slide and we'll move to your next slide.
All right.
So I did a chart with the cumulative number of tests per place. So you see the line is going up because more and more of the population of a place, in most of these cases, countries, have been tested. And it was interesting. So if you look on the left, it's a log scale. So it's like 1,000 would mean that this is up per 1,000. So 1,000 would mean 100% of the country's population has been tested. As you can see, looking from left to right, I know there are lots of colors and lines. The standout is Iceland, which has rapidly gone up to over 10% tested. Most of the other countries, developed places, are between 0.1 and 2%. So if you look kind of in the fine chart, you can actually see the US has done I think a remarkable leap in testing. going from below many countries to above South Korea, in fact, which was previously touted as a aggressive tester, as well as the UK and Malaysia. Taiwan, in fact, if you look, is not very high on testing, and yet they have a very low confirmed cases, which suggests that I think they're not seeing many new cases and they don't need to therefore test. Maybe that's an interesting discussion. Singapore, I kind of made in very bold letters, markers. There are not many points from the data source I got. So the number of tests is in the region of 2% and rising. Probably a lot actually to do in the last 2-3 weeks of the migrant worker dormitories. But if you look down all the way below Taiwan, you can see that large countries like Indonesia and Bangladesh have really low testing rates relative to the size of the population. If it wasn't a log scale, they would just be looking at 0.
Yes. So you make a good point. Iceland is the flag bearer of testing. In the very beginning, they made a concerted effort to try to test the entire population, as many patients as possible, and also to the populations that they can gather information. So they did. They have tested more than 10% of their population, and that is the first data point that to suggest that there's a lot of asymptomatic patients out there that they don't even report any symptoms, and the first data point from Iceland is that there are more than 50% of the asymptomatic patients that came out from the Iceland study. And so the US population, they are being tested at the right now. If you follow the trend, there is a pretty rapid increase at the end of April, at the beginning of April or end of March. Before that, there is almost non-existent testing that in US. But within these 3 weeks, 3 to 4 weeks, they are rapidly ramping up. A few reasons is people realize that massive testing is one of the ways to try to contain the virus, and after that, with active tracing, then you will be able to know the extent of that. And the other thing is that there are better and faster testing equipments that came out. For instance, the Abbott laboratory, they came out with a 5-minute testing, and up to now, 1 million of them has been shipped and tested in primarily in USA, because that they just reserve as many machines as possible. So over the years, over the past 3 weeks, there's been a very robust increase in US. And for the case in Singapore, one thing that they are doing great is that they do infected people, and then they do contact tracing, and they do a very smart way of trying to follow up the disease. So in the sense that although Singapore has about 2% being tested, but they are doing it in a much smarter way of trying to use the contact tracing to help them to understand what is the extent of the epidemic. So so yes, in the sense that the 2 key lessons from South Korea is contact mass testing and contact tracing, and Singapore has done a marvelous job in that. So the cases are there's a lot of cases in Singapore, but I think there's the majority of the cases are being caught by the Singapore Health Authority. That is the good thing. So that I think it should be contained relatively quickly in Singapore because of the mass testing plus the contact tracing. Does it answer your question?
Yes,
Hello?
very good analysis. Thank you, Dr.
Yeah.
Thank you. Let's perhaps move on to this whole notion of how infection is measured and what we mean when we're talking about flattening the curve.
So shown on the left is that is the initial study from Wuhan, and then the curves, the red and blue and purple are estimated the reproduction number, which is the number of which they measures what is the number of patients that has subsequent infection from the original infection. So R0 of 3 means that one patient will subsequently infect 3 patients. R0 of 2 means that one will infect subsequently 2 patients. So although there is a very small difference between R of 3.1 to R of 1.9, you can see that because it is an exponential growth, there is a huge difference between the number of patients if our number is 3 versus around 2. And they estimated based on this the infection rate, the reproduction number of the patients is about 2.5. So how does that help to combat the epidemic? If you try to reduce the number of infection reproduction number, what you are trying to do is you bring down the affected patients to the level where the health care system can cope, and that is shown on the right. Without any preventive measure, there will be a huge spike, like what is shown on the left, and it would overwhelm the healthcare system. That is what happens in Italy in the beginning of the outbreak. But if you try to reduce the number, to reduce the RO, the reproduction number, what you do is you try to flatten the curve such that you do not exceed the healthcare system capacity, and therefore everybody can be adequately treated. Right. So next is what are the diagnoses? The first wave of diagnosis is called the RT-PCR machine. It's run by a machine. It needs some specialized technicians to run it, and it takes about 3 hours to get a result. The next generation of the test is called a rapid detection test. Shown here are the Apple one, and I know that Singapore has their own version of that too. So that is about, usually it takes 5 to 15 minutes to run it. And right now there's more and more people using this machines to run. And the requirement is that you still need a machine to run it. And the most exciting development right now is called the CRISPR-based detection. And that the website down there is shown that you can go to their website and take a look. What it does is that it can be miniaturized and it can be made like the antibody test, like a pregnancy test kit. And it takes about an hour to read. But the key thing is that there is no, you don't need training to really run it. Most healthcare professionals, once it is trained, they can use to test it. But one thing is that they are still under development. But this thing can potentially be rolled out to most countries, developed and underdeveloped countries, because it can be miniaturized, it can be used, it can be simplified, and it can be it will be a big arsenal for detection of the virus. So the other type of test is to test the antibody, and what it does is that it tests whether you are exposed to the virus before. The first 3 tests is that to test whether you are currently having an infection. So they do serve different purposes. So the RNA testing is testing whether you currently have this disease. And the antibody is that whether you have exposed to that in the past, right? So those are the tests that are run. And the vaccine trials, there are many type of vaccine trials. In fact, there are right now, I've seen there's more than 70 clinical trials that are registered, but not some of them has not rolled out to recruit patients yet. But definitely, it's an extremely active area for the pharmas and the biotech companies to follow up. The first one is the DNA or the RNA vaccine. It's a naked DNA or a naked RNA. What it is that it's the pros is that it's very easy to scale because it's a very simple molecule. A lot of people can make it. Of course, if you want to make it in the GMO, the good manufacturing GMO standard that is used in the clinical trial, you do need some specialized facility, but this thing is quite easy to scale. So you can definitely have millions of kits of vaccines that are being rolled out. The latest, it's one of the fastest, and right now there are companies already in phase 2. There's 3 phases in the clinical trial. So once you pass those 3 phases, then you can have that the vaccine that is registered. So the other thing is the subunit of vector vaccine. That what it is that they produce a particular protein. For instance, the surface spike protein on in the COVID-19 case, and what it is that both GSK and Sanofi are big companies that are doing that, and right now it's in phase 1 or 2. The last one is the attenuated or live inactivated vaccine, and they are the weakened virus or a dead virus, and they are companies that are doing that. And right now, most of them are in phase 1 and preclinical. So vaccines, the hope is that the first efficacy readout for the last clinical trial would be expected first half of next year. So this year is really hard. I see that it would be very hard to have a definitive result before end of this year. So that is a timeline. Next is the on the treatment, you can target the virus, you can target the information or the receptor, or you can use the patient's plasma sample to use it as a passive immunity. And all these treatments are, if it is successful and very smooth, it could be months away for those. But of course, right now, none of the antivirals that are being tested has shown to be effective, and the whole informations are being a lot of them are recruiting patients now, so it will take a while for them to see whether they are effective. So, and the plasmas, the recovered patients' plasma, there are people who are starting to trial it as a proof of concept. So, and all those, if any one of those are successful, it will be the timeline is probably the quickest would be months. But if you are talking about starting a completely new project, that would be too late for this disease right now. So commonly asked questions, I think those are the questions that I put, but you can, I can just do rapid fire. The origin of the virus is probably from the bat. Are you immune to COVID-19 if you have it? The WHO warned against that if you have COVID-19, it doesn't guarantee you the immunity. But what I from the virology aspect, it probably would be protective at least for months, if not years. So at least you will be protected for months. And does the mask protect yourself or others? It depends on what kind of mask that you have. The N95 mask does protect yourself. The surgical mask mostly protects other people. So, and then why does some people has more severe disease? It's mostly due to your own immune response against this particular virus. And vaccines takes long because you need to show effectiveness, and you need to show that people with vaccines are less likely to get the disease. So to get statistical significance, you need to have it longer. So does warm weather stop the outbreak of COVID-19? Warm weather does have an effect on the growth of the virus, but knowing that we have in Singapore, there's a lot of virus that are circulating, it doesn't completely eliminate that. It just slows down a little bit. So I would say that, you know, for people who thinks that by the summertime and the COVID-19 is going to be gone, it would be a hard. It would be a surprise that they would go down a little bit, but it probably wouldn't be gone unless there are effective treatment or effective vaccine available. Final thoughts. Majorities are mild, asymptomatic or mild. So just bear in mind that, you know, even if in the case that you got it. Hello?
It's all right. Again, please go ahead.
Okay, so if you are sick, stay home. But if you have difficulty breathing and persistent chest pain, then you should consult your medical staff for admission to the hospital. A prolonged exposure is needed. Usually it's more than 15% within 2 meters. So jogging, walking, it's all right to have people jog and walk and running outdoors. Those will not get you infected. Children are also very susceptible to this virus. However, most of them have very mild symptoms or not at all. So children are not immune to that, but in fact, it could be a silent carrier that they carry the disease without anybody knowing it. And seniors with underlying conditions are more prone to severe disease. Virus can stay on for surveys for at least for a couple hours, and in ideal conditions for days, but that is detection of the RNA. It doesn't detect the virus. What I would think is that it will probably stay for at least hours. Days, it probably is just the RNA that is being there, not the infectious particle. So there are huge unprecedented collaborations between pharma, biotech, academic, philanthropic organizations. So that is something that people realize that this disease we cannot solve this disease alone. And a lot of people are very keen on collaborating with each other, which brings the good nature of you know, to try to combat the disease altogether. And constant washing hands and avoid touching faces and social distancing remains the best method of prevention for now. I think I'll take some questions because I know that there's a lot of information out there, and I'm not sure that you know, I mean, people that they got the right information or not. So I open the floor for questions.
Well, thank you, Yen, very much for that update and some of, you know, the information you've been presenting to us. We did have a couple of questions come through the chat window, which I've added to the list here in terms of the commonly asked questions. if you could just kind of take a look at them and
How many
walk
others?
us through it. So look at
Okay.
question 9, for example.
Let me see. I mean, okay, I am.
No worries, let me read it out. How would the initial
Okay.
production rate of the COVID vaccine scale relative to the current production rate of influenza vaccines?
All right, good question. If you are talking about a DNA RNA vaccine, there would be no overlap because the influenza vaccines are either produced in tissue culture or with the egg. So that if you are talking about the first kind of vaccine, there'll be no interference whatsoever. If you're talking about the second type of vaccine, which is the envelope, when it's the subunit of vector vaccine, there's also no overlap because they can be produced not in the tissue culture or not within the egg, but you can use another method to produce that. What it would be affected is that if you come up with an attenuated or inactivated vaccine, most of the current flu vaccines are being produced by this method, and that would be an impact. So I think people are already start looking into that and trying to see if they can scale it to millions of doses. So for the first two type, it can be scaled. So the first type is easy to scale. The second type, there are companies, the GSK and Sanofi. They are two of the biggest vaccine companies, and they are committed to produce hundreds of millions of doses if their combined effort proved to be helpful. So that is, you can for the first two, it's covered. For the third one, I think people are working on that. Okay, the AC receptor can be found in other organs. Yes, does it mean that all we can spread? Yes, in the sense that anything that has ACE2 receptor, the virus can invade to those cells. However, whether they cause any symptoms on that organ is not known at this moment, right? 11, is it true that it is more difficult to come up with a vaccine for RNA virus than DNA virus? Not quite. I mean, both. You really need to know that how it is responsive to how immune system respond to the vaccine that you're given. For instance, the yellow fever vaccine has been one of the best vaccines that with more than 90% effective rate, and that is RNA vaccine. So some vaccines are just not very, they do not have the good response from the immune system, and that is the key. That that would be the key for whether the vaccine can be done successfully. And at this point, it's really hard to predict that whether COVID-19 falls into the category of easy to produce vaccine or hard to produce vaccine without really, testing the vaccines, whether they elicit strong immune response. So it's hard to tell right now. Is it true that it is more difficult to come up with a vaccine? Oh, okay. There was a recent article in Washington Post on the high incidence of strokes and blood clot related to young patients without underlying disease. Would you happen to know if this is alarmist or something that should be aware of? I'm not aware of that. young patients having a high incidence of stroke and blood clot that particularly affected the young. So I think there are, when people look at this, what people look at is that if you are a young patient and you are unlikely to die, then if there's something that happens, that it gets scrutinized really strongly. And I think that without any additional evidence that I can see, I think those are incidental cases and not something that I would say that it is a systematic prevalence that young patients could have, could be more prone to strokes or blood clot.
Wow, that's indeed rather concerning.
Yeah. So is there any additional questions or anything?
Yes, we do have another couple more here.
Yeah, so I've done those to have second COVID tend to get worse or symptom outcomes. Okay, so on this topic, there is no definitive answer, and that if you have COVID-19, you will you are even prone to you are either you are not immune or you are prone to secondary infection. At this point, I think the jury is still out because as you know, the disease is very only recently there, so there's not enough the data to support this. So I just think that it is just too soon to say definitively, and the immunity should last at least months from all the viruses that loses immunity. At least they seroprotect for months, like 6 months or so. So at the very least, you should be protected for 6 months. Whether you can have a lifelong protection, it is still out. It is the jury is still out, and whether there is the secondary infection is stronger than the primary infection, like what we've seen in dengue, the jury is still out. Is there, this is a virus that would mutate fast enough the vaccine to be rendered effective. This is an RNA vaccine, and this is an RNA virus which has the potential to be more mutable. However, at the data that we've seen right now, the mutagenesis rate is neither low nor high. So I would not say that it would be very quickly rendered ineffective, but at this moment, I don't know how much mutation that there is for it to be for the vaccines to be inactive. So I would say not like those like where you have co-vaccines that once you administer, you have to administer every year, but because of the fact that it is an RNA vaccine, it could render ineffective in, let's say, in coming, not in months, not in a scale of months, but maybe like a few years maybe. So that is my judgment at this time. Can it spread from jogger? Like I said, you need prolonged exposure for that to happen. And if you run, actually, if you run, the droplets fly past you most of the time because there's air current, so it won't stick to your face, and there's very little chance that it sticks to your face. So if you run and if you don't stick to a person within 6 minutes for a prolonged period of time, you should be safe.
Got it. I know there's been some information circulating around slipstreaming and catching it from there. I think that's why this came up as well.
Yeah, so Joker,
Research.
if you don't stick to one person for extended period of time, you're safe. Is there any correlation between COVID-19 and pneumonia? The correlation that I've seen is from one paper, the BCG, and if you ask me, it's pretty weak. So I wouldn't think that there is a possible treatment plan. There is only correlation. That means that people who has BCG tend to be the countries that administer BCG tend to be the less infectious, the countries that are less infectious. But that is just correlation. I don't think that at this point, the scientific data is strong enough to support that. Okay, so do we know if there are long-term side effects even after recovery of COVID-19? Yes, I think lung scarring is one thing that because it is a very new disease, but people coming out of this, people who are recovered from this disease, a lot of time for the severe patients, their lung is scarred and their breathing capacity is much lower, and it remains to be seen. And it does appear that they could slowly recover a little bit, but I don't know whether there will be a full recovery. And for the smell and the taste, in the previous SARS scenario, in the 2003 SARS, majority of the patients that they lost taste and smell do recover, with extended period of time. Very, very few patients lost taste and smell completely. So my bet is the long-term side effect will be recovered for most patients. Some phylogenetic studies suggest that there's more the strains that are more virulent in New York is more than the West Coast. What I know is that they are slightly different variants of the strains. For New York, it's from Europe. For California, it's mostly from China. I don't think that so I don't know about whether this is true, because I have not studied that, so I don't want to make any judgment on that. Would it be possible that multiple vaccines would be required for multiple strains? At this moment, no. The variations are still within the same serotype, in the sense that if your antibody recognize it, it won't be, after a certain time, it will become non-recognizable. So at this moment, the data still suggests that it won't happen, that multiple vaccines will be needed. Are there studies showing how infectious a person at various times of showing symptoms? Yes. You start getting infectious a day or two before your symptom appear. So those people who has and after a week of symptoms, your viral load, the virus in your body starts to go down, and you become less and less infectious. So with that, if still showing mild symptoms, are they still infectious? I cannot tell for sure that they are infectious, but the infectiousness is reduced for sure. But I cannot tell for sure whether they will not be infectious at all. Yes, I think, more, sorry.
Oh, that's amazing. I know, actually,
Yeah.
to be fair, Yen, I know we're coming to the last 10 minutes of the session here today, but we actually precisely have a session survey just so that we could have you prep for some of these questions. So I know some of these are coming out of the blue, and you've been super kind in terms of helping us kind of address all of these. And maybe there aren't even answers for this, but I certainly appreciate your perspective. So we do have a few more, but I'm going to just maybe stop it at these final two that are out there.
All right. So has there ever been a vaccine for SRS? What is SRS?
I think it's SARS, I believe.
Oh, SARS. Okay, I see. No, there's never been a vaccine for SARS. What is the likelihood that one would develop for COVID-19? Good question. I don't know. It will be a $1 million answer if anybody knows. Everybody
million
is
only?
trying
I
their,
think far more. Far more than million, I think.
Yeah, $1 billion question. So the fact that there's more than 70 clinical trials means that nobody knows. They are throwing all the darts and they are throwing the darts and see which one sticks. Nobody knows at this moment. Yeah. So they are am I exploring future? I'm wondering that qualities, okay. So for the research team, for us, we need biologists, we need chemists, pharmacologists, clinical science, statisticians. So I mean, all the hardcore science, we needed them, maybe except physics. But other than physics, because it is a very multidisciplinary collaboration. Otherwise, you need to understand the body very well, the virus very well, to make the compound that tackle these questions and to make sure that the body is not harmed by this. So you need a multidisciplinary team. And when we have meetings, it's always consists of various expertise from the team. So any hardcore except for physics, I think the main thing is there are three: biologists, chemists, pharmacologists.
Yeah, that makes a lot of sense. Thank you. I think a lot of folks are probably feeling like this is an important field to be in, given that we're all, you're all waiting, right, for that solution. And it'd be great to be able to inspire some young folks to take this up as well, to help in this fight. So it's been wonderful hearing from you. Thank you. Sorry, Yen, were you about to say something?
No problem. I mean, if there are other questions that I can address, that just write to me. Let me know. I'll try to address them.
That's brilliant. Thank you. I think one thing's at the back of our minds that's pretty clear that you did not mention is that we should not inject bleach into our bodies at this point.
Certainly. I think that you're absolutely right. The injection or drinking bleach, will kill you faster than curing the virus.
Great advice. Thank you very much, Yen, for today's session and for all the information here. I know that many folks have additional questions, as you've offered, can reach out to you too. That's great. So let us perhaps move on to just rounding up today's session. We did cover a number of different topics, right? We covered the surge in terms of what's happening in Singapore of cases. We covered the opportunity to help, for those of us who might be interested in supporting from a technology perspective, what the Singapore government is doing out there, or basically essentially what the world is doing out there from a technology perspective. And then we covered as well some of these COVID-19 facts, right, that you've been sharing with us in terms of the fight against COVID-19 and the search for the cure. Let me just go around the table here in terms of our guest speakers to see if there are any parting words for us. Daryl, do you have anything to add with respect to what MFA is observing and what's happening in Singapore.
Yep, but a shout out to also to SGN as well as to SingaporeConnect actually for providing us 3 excellent speakers over the past 3 weeks. Thank you very much.
Mm-hmm. It's been amazing. Thank you, Daryl. I think it's been amazing having you folks from Singapore, you know, the Smart Nation team, the Singapore Global Network, as well as these guests, as well as all the different guest speakers, right? Really sort of step up, right, to share our expertise. And we certainly are looking forward to hearing, in fact, from more speakers as well. For those of you who have expertise and would like to share some aspects of what you've learned and what is happening out there, certainly please feel free to reach out to us too. Now let's go on perhaps to Singapore Global Network. You know, Karen, you talked about the opportunity to step up, right, to support the efforts there. Any final words before we part for today?
No, Jasmine, I think that's all from us, and we very, very grateful to everyone who's already volunteered, or, you know, not just on the tech front, but in the community front, the social front. I think that's really important right now. So thank you, and all of you out there.
Awesome. David, you've been very much behind the scenes, pulling together this meeting, you know, kind of getting the word out as well to the community, and keeping us all posted of all the different updates throughout the week. Any comments from you?
Hello, Jasmine. So I think everyone has been very kind to pull together all these sessions. As I mentioned for previous weeks, it's really a lot of work. And one thing you might not know is that actually for Dr. Chen especially, so one thing is he volunteered for this session 2 weeks ago. So that's one. And secondly, his family actually just came back from Singapore middle of this week. So he has been very, very busy. But despite all these things, he actually he spent a lot of time on the slides and working with us on the prep for this session. So really, really shout out to him. Thank you so much for his effort, and just so happy to see the Singapore community coming together in the US in spite of all this situation going on. And really, for those of you out there who are wondering, maybe you have some expertise you want to share, feel free to reach out to me, reach out to Jasmine, Mark. More than happy to talk you through. And similarly, if you have interest to help to volunteer for the session, whether there's a lot of prep work that goes behind this, whether it's things like preparing the slides, whether it's things like helping Jasmine with some of the survey questions and things like that. There's a lot of background work that needs to be done. Mm-hmm. So really do feel free to reach out to us. More than happy to discuss with you and see how we can make things work for everyone. Yeah, thank you so much.
Great, thank you, David. And indeed, a shout out to Jennifer as well as Rachel, who have been helping us behind the scenes to compile all this information and to get, you know, the decks even ready, right, from the survey and all that in really tight time frame, since we typically don't get results till about 6-7 o'clock in the evening. So many thanks to the both of you for really kind of rallying together. And I must say, Dr. Chen, it's so great to have you on the call, and I'm so proud that, you know, one of us is actually out there, right, fighting at the forefront, right, to solve this and to provide, you know, to work on finding the cure for coronavirus and some of these major viruses. So very excited to support you in your efforts, and very glad that you're able to share with us here. Final word from Mark Sin, our president from SingaporeConnect, as we wrap up this evening. Mark?
Great. Thanks, Jasmine. I'd also like to share thanks to Jen Tan for helping earlier with the slides, and to Wilson Koo for doing so much to, I think many of you are aware, in the community forums, chat groups of doing the reach out to the restaurants to get lots of food delivered. So if you haven't actually heard, please do check the Facebook pages or groups for that. To other topics, besides the serious-ish kind of topics that we've been having for these forums, there has been some thought. Can we do something a little more light, such as entertainment? Could be a quiz, could be a virtual sing-along, could be a virtual makan. If you have suggestions or you're actually interested to volunteer, as David Ho said, do reach out, especially if you'd like to host something like that. We can certainly also make use of a different time instead of this. So we're not talking about replacing these series of updates, but possibly having a more light kind of event, since I think we all need a little cheer at these times to keep our mental health up too.
Great. So with that, let us wrap up for this evening. Many thanks for all participants and for all of you and the guest speakers as well for this active sort of interaction. we'll see you again next week, and hopefully we bring better news on the situation in Singapore, and as well as the search for the cure. Thanks, guys. Stay safe. Bye for now.
Thank you.
Thank you so
Thank
much.
you.
Bye for now.
Thank you, everyone.
Good night.
Good night.
Good night.